pharmacology right now. I mean, to ground our professional academic insight into this topic, as highlighted by Dr. Asifullah at KMU IMS Kohat, the fundamental challenge in pharmacology here has always been the biologic delivery barrier.
The biologic delivery barrier.
Right. That's the challenge of getting large, highly complex molecules to actually survive the digestive tract. Because, your stomach is just this vat of acid and enzymes.
Right. It's designed by evolution to destroy stuff.
Exactly. To break complex proteins down into basic amino acid building blocks. So historically, if you swallowed a biologic drug, your body just saw it as lunch.
Which perfectly explains why for like the past decade or so, if you needed a PCSK9 inhibitor, you had to inject it.
Yep.
Because these are those incredibly potent biologics for lowering bad cholesterol. We're talking about drugs like evolocumab or alirocumab.
Which are monoclonal antibodies, or MABs, yeah.
Right, MABs. And because you couldn't swallow them, patients were basically forced to go to a clinic or use an auto-injector at home, which, obviously creates a massive bottleneck in patient care.
Oh, absolutely. Monoclonal antibodies are brilliant pieces of science, but physically, they are massive, heavy proteins.
Just structurally huge.
Yeah, structurally huge. And because of that massive size, they absolutely mandate subcutaneous injections, usually biweekly or monthly. And while they are, highly specific and wildly effective at finding their target in the body, the delivery method drives widespread needle hesitancy.
Oh, for sure. Nobody likes needles.
Right. It's a huge issue in preventative medicine. A significant percentage of patients simply do not like giving themselves injections. And that psychological and physical friction directly leads to non-adherence. People skip doses, or they just flat out refuse the therapy entirely.
Even when their cholesterol levels put them at imminent risk for a heart attack.
Exactly.
Okay, let's unpack this, because the obvious question you'd ask if you were looking at this from the outside is, why not just make a normal pill?
Right, the obvious pivot.
Yeah, like most pills we take, like an aspirin or a standard statin for cholesterol, are what we call small molecule drugs. So the biologic wrecking ball is too big and has to be injected. It seems like scientists should have just engineered a small molecule to do the exact same job against PCSK9.
You would think so, but what's fascinating here is the sheer geometry of protein interactions. Small molecules are exactly that. They are tiny.
Right.
They are fantastic at slipping into small, deep, pocket-like crevices on the surface of a protein to block it. The problem is that the PCSK9 protein in your liver doesn't have a convenient deep pocket.
It doesn't.
No. Its binding site is a very large, flat, shallow surface. So a small molecule simply lacks the physical footprint required to block that interaction.
Okay, I see. It's like trying to cover a massive pothole in the road with a single postage stamp.
That is exactly it.
Like, it might sit right in the middle of the hole, but it doesn't cover nearly enough surface area to actually stop a car tire from hitting the damage.
That is the perfect way to visualize it. And that brings us to the actual biology of what PCSK9 is doing in your body. On the surface of your liver cells, you have these LDL receptors.
Right.
Think of them as microscopic vacuum cleaners that pull LDL, the bad cholesterol, out of your bloodstream.
The vacuums we want working.
Yes. But PCSK9 is a protein your body produces that naturally binds to those vacuum cleaners and tags them for destruction.
So if you have too much PCSK9, your body destroys all its own cholesterol vacuums, leaving the bad cholesterol to just circulate and build up as plaque in your arteries.
Precisely.
Meaning the goal of the drug is to block the PCSK9 so the vacuums can keep working.
Yes, that's the goal.
But if a small molecule is like a postage stamp that's way too small to block it, and a monoclonal antibody is this giant wrecking ball that requires a heavy-duty delivery truck, the needle, then what exactly is Lipfendra? Because the clinical data refers to it as a macrocyclic peptide.
Right, the macrocyclic miracle.
Yeah.
That is the Goldilocks solution bridging the gap. Macrocyclic peptide engineering is basically a masterclass in structural biology. A macrocyclic peptide is physically larger and much more complex than a traditional small molecule.
So it has the footprint.
Exactly. That gives it the necessary surface area to lock precisely onto that large flat surface of the hepatic PCSK9 in the liver. It effectively halts the destruction of your LDL receptors.
So it has the size to do the job. But wait, how does it survive the stomach acid? If it's larger and made of peptides, shouldn't the stomach just digest it like it does the monoclonal antibodies?
Well, this is where the macrocyclic part comes in. It is engineered into a cyclic or circular structure.
Like a loop.
Yeah, exactly like a loop. Because it loops back and folds in on itself, there are no loose ends. It essentially hides its vulnerable chemical bonds from the digestive enzymes in your stomach.
Oh, wow.
Right, so it achieves the precise targeted blockade of a massive biologic, but with the oral stability and viability of a small molecule.
That is just an elegant piece of structural engineering. They basically forged a 3D printed smart key, perfectly shaped to lock onto the PCSK9 target, but they built it tough enough that you can just swallow it.
Yep, just take it with water.
But, let's look at the actual clinical outcomes, because I'm naturally skeptical when we adapt a therapy purely for convenience.
Sure, that makes sense.
Usually when you make something easier to take, you sacrifice some of the firepower. So if this oral smart key is going to replace the injectable wrecking ball, does it actually work as well as the wrecking ball?
Your skepticism is completely warranted, but the phase 3 coral reef data is what elevates this from a neat scientific trick to a true medical paradigm shift.
Okay, let's hear the numbers.
If we look specifically at week 24 of the trials, the lipid reduction dashboard is, frankly, astonishing for an oral medication. The data shows a 56% to 60% reduction in LDL-C, the bad cholesterol.
Wow, 60%.
Yeah. Alongside that, they tracked a 50% drop in apolipoprotein B, or ApoB, which is the primary structural protein backbone of those plaque-building particles.
Right.
And perhaps most notably, a 28% drop in lipoprotein, which is a stubborn genetic cardiovascular risk factor that traditional statins basically barely even touch.
Wait, I need to make sure I'm framing this clinical context correctly. A 60% reduction in bad cholesterol is massive in a vacuum.
Right.
But looking at the patient baseline in this coral reef program, these aren't people starting from scratch.
Not at all.
These outcomes were achieved in cohorts that were already receiving maximally tolerated statin therapy.
That is the most crucial piece of context in this entire deep dive, yes.
Wait, so we are taking patients who are already maxed out on their statin therapy. Like, their doctors have pushed their daily dose as high as it can safely go.
Redline the engine?
Yeah, exactly. They redline the engine on traditional cholesterol clearance. And by adding this one daily pill, we are dropping their LDL by another 60%.
Yep, another 56 to 60%.
That's not just a marginal gain, that's a clinical cliff drop.
It is a profound secondary strike against cardiovascular risk. And to directly answer your pushback about whether the pill matches the pen, the established injectable monoclonal antibodies that patients have been taking for years typically deliver roughly a 60% reduction in LDL-C.
So they are essentially matched.
Exactly. This new oral macrocyclic peptide is hitting 56% to 60%. The synthesis is undeniable. The outcomes of this daily pill completely rival the established clinical potency of the injectable alternatives.
Okay, but this naturally brings up a massive red flag for me, and likely for anyone listening who has struggled with intense cholesterol medication.
The side effects.
Yeah, because there is no free lunch in pharmacology. If we have this highly potent oral pill that is dropping cholesterol levels through the floor while compounding the effects of a maximally tolerated statin, my immediate worry is that we are overworking the liver or the muscles. Won't this just amplify the infamous side effects of statins?
It's a very logical concern. When you combine two powerful drugs, you often do get compounding toxicity.
Right, because muscle pain is like the #1 reason people abandon their statin prescriptions.
Oh, without a doubt. But this is where understanding the biological mechanism of action we discussed earlier becomes so important. Statins work by inhibiting an enzyme in the liver called HMG-CoA reductase, which is an upstream part of the cholesterol production pathway. They essentially stop the liver from manufacturing cholesterol in the first place.
Gotcha.
But Enlicitide, our new oral PCSK9 inhibitor, works on a completely different downstream pathway. It binds to PCSK9 to prevent the destruction of the LDL receptors.
The vacuum cleaners.
Right, meaning it just allows the liver to vacuum more existing LDL out of the blood. Because they utilize completely distinct mechanisms, the side effect profiles do not stack on top of each other.
Oh, that makes a lot of sense. So if the mechanism is completely different, what does the clinical safety data actually show for Lipfendra? Because the infographic highlighting the statin contrast is pretty stark.
The safety data reveals a highly tolerable profile. For the standard primary hypercholesterolemia cohort, your average high cholesterol patient, the safety profile was virtually identical to the placebo group.
Wow, virtually identical.
Yeah. But the real contrast, as you noted, is against statins. With this new drug, there is zero risk of severe myopathy, which is that severe debilitating muscle pain and weakness that forces so many patients to quit statins.
Yeah, it's huge.
And furthermore, there is zero risk of new onset diabetes, which is another known, albeit small, risk associated with long-term high-dose statin use.
Here's where it gets really interesting, because zero risk of severe muscle pain. That single data point is going to make this incredibly appealing for a huge subset of patients who just fear statins.
Absolutely.
But what about contraindications? Are there any heavy black box warnings we need to be aware of?
There are no heavy black box warnings at all. The contraindications are restricted exclusively to patients with known severe hypersensitivity to Enlicitide or its excipients.
Which is standard boilerplate for almost any pharmaceutical, right?
Exactly. Even when the trial looked at the specific target subpopulation of HeH.
HeH, that's heterozygous familial hypercholesterolemia.
Correct. Which is a severe genetic condition requiring very aggressive high-dose lipid lowering. The adverse events reported were remarkably mild. We were talking about mild dizziness in about 9% of patients and diarrhea in roughly 7%.
That is a remarkably clean safety profile for a drug delivering an additional 60% LDL reduction on top of statins.
It really is.
All right, I'm playing devil's advocate here because you are painting a picture of an absolute unicorn drug.
Fair enough.
We have a highly potent oral pill. It survives the stomach acid. It drops bad cholesterol by another 60%.
Right.
And it basically has none of these statin-like side effects.
Yeah.
I mean, there is no free lunch in pharmacology. What is the catch?
You're entirely right to look for the trade-off.
There's got to be one.
There is indeed a catch. But the catch isn't toxicological. It's entirely logistical.
Logistical.
Yeah. The compliance barrier has simply shifted. We've successfully engineered away the needle hesitancy and the annoying storage logistics of keeping injectables refrigerated in your kitchen.
Right.
But we have traded that for what the clinical data officially calls a complex fasting window. The The sheer mechanics of absorbing this fragile peptide through the stomach lining demand a very strict, unyielding daily routine.
Ah, okay. I'm looking at this clock diagram and the sources detailing the 30-minute absorption gate protocol.
Yes, that's the one.
If I'm understanding this right, this is going to heavily dictate a lot of morning routines for the people taking it.
It absolutely will dictate their mornings. The base dosage is one 20-milligram tablet taken orally once a day. The first rule is structural. You must swallow it whole.
So no chewing.
No chewing, and you cannot crush it into applesauce or anything like that. Doing so would destroy the structural integrity of that macrocyclic ring before it even reaches the stomach, exposing it to instant destruction.
Makes sense based on what we talked about.
But the real hurdle is the fasting buffer itself. You must take the pill on a completely empty stomach, and then you must wait a strict minimum of 30 minutes before consuming anything of substance.
Okay, when you say anything of substance, how pedantic are the guidelines being here? Like, what is actually permitted during that 30-minute waiting period?
It is remarkably pedantic. During that 30-minute window, you are permitted plain water, black coffee, and plain tea. That is the entire list.
So, practically speaking, what does this all mean for my morning routine? If I wake up, swallow my Lipfendra with a glass of water, and then pour just a splash of oat milk into my morning coffee while I wait to eat breakfast, I basically ruined the peptide absorption.
Right. Yes, you absolutely have.
From a splash of oat milk.
Anything on the strictly restricted list, which includes all food, nutritional drinks, supplements, any other medications you might take in the morning, and yes, your oat milk or creamer, all of that will trigger your digestive system to release a wave of enzymes and acids.
Oh, because the stomach wakes up.
Exactly. Even a tiny amount of calories signals the stomach to start the digestive process, which will unfold and neutralize the peptide before it can successfully cross the gastric barrier into the bloodstream.
I see. It's like a VIP club. Only black coffee and water get past the stomach bouncer for those 30 minutes. If oat milk shows up at the door, the bouncer just shuts the entire club down, turns on the lights, and the drug doesn't get absorbed at all.
That's a highly accurate way to visualize it. The macrocyclic peptide needs a perfectly clear, inactive runway to be absorbed intact. If you introduce any other variables, the runway is instantly closed.
Wow.
And importantly, this strictness even applies to missed doses. The clinical guidelines state that if you miss a dose, you can take it later in the day upon remembering, but only provided that the strict 30-minute fasting buffer is strictly maintained before your very next meal.
So you can't just casually take it with your lunch because you forgot it at breakfast?
Exactly not.
Wow. Okay, so understanding that intense VIP club morning routine really clarifies exactly who this drug is actually for and how it integrates into the broader clinical picture of preventative cardiology. Because this clearly isn't just something you hand out like a daily multivitamin.
Precisely. The prescribing indications strategically target two main groups of patients who are failing to reach their target LDL goals on statins alone.
Okay, who are they?
The first group is primary hypercholesterolemia. These are adults who need an aggressive adjunct to diet and exercise to reduce their LDL-C. And practically speaking, these are individuals facing logistical or deep-seated psychological barriers to injectable therapies.
So they desperately need the massive reduction, but they absolutely refuse the biweekly needles.
Exactly. And the second group is the HeFH cohort we mentioned earlier.
Right, the high-risk genetic cohort.
Yes, these are high-risk cardiovascular patients with a genetic predisposition. Their bodies naturally produce and retain dangerously high levels of cholesterol, and they require aggressive multi-pathway lipid lowering just to reach a baseline level of safety.
So it's essential for them.
For them, combining a maxed-out statin with an oral PCSK9 inhibitor isn't just about convenience, it's a life-saving compounding effect.
So it's not replacing statins, it's the ultimate tag team partner for people who hit a wall.
That is the exact clinical integration model. It's the new oral adjunct. First-line therapy is still going to be maximally tolerated statins, but it steps into the ring and essentially normalizes PCSK9 inhibition.
Right, transforming it from a specialized biologic intervention into standard daily clinical practice.
Exactly.
But honestly, I have to bring up the behavioral side of this. Because human behavior is notoriously fickle when it comes to medicine. Does a strict 30-minute daily fasting window really beat just taking a shot every 2 weeks for most people? I mean, 30 minutes of strict discipline every single day versus a 5-second injection every 14 days.
It's a fair question. But if we connect this to the bigger picture of patient psychology and medicine, the answer is a resounding yes for a massive subset of the population.
Really? Even with the daily friction?
Yes, because what we see clinically is that empowering patients with an oral choice fundamentally changes long-term adherence rates. Yes, the fasting window requires daily discipline, but it is an active, routine discipline that easily integrates into a morning schedule.
Okay, I can see that.
An injection, even just biweekly, is perceived as an invasive medical event. It causes anxiety. It requires specific